So hello everybody, welcome to our 28th session of our ESTM webinar. Today's topic is again case-based scenarios, and at this time we are talking about generalized epilepsy. We have two distinct speakers, which is Arthur Cookhead from Sao Paulo and Mark Richardson from Boston. We're gonna start with Mark's cases, and we will then do Arthur's. And for all that are listening, please be interactive and put questions into the chat. And so, Mark, this is your turn.
Great. Thank you, Christian, and the rest of the organizers for the invitation to talk in this really wonderful series on surgical techniques. You see my screen okay?
Yes. Yeah, it looks great. Thanks.
All right, great. Okay, so I'm going to talk about centromedian region RNS implantation, which is the way that we've been treating generalized epilepsy now for several years. And I know this is a case-based type presentation series. One thing about these cases with IGE is they really can be stereotyped. And so a lot of the important surgical steps are related to selection of the patient and the rationale for the treatment. So I thought I'd spend some time just describing why we use RNS. Of course, we're able to do that in the US. I understand that this isn't available around the world yet, but I think some of these principles are interesting to consider as other types of devices come online and become available. So although we typically don't think of generalized epilepsy, at least the field doesn't think of it that way, as a surgical disease, a lot of these patients are refractory to pharmacological treatment, 25 to 50%, depending on the review article that you read. So again, we've used RNS in the centromedian region, and there are a few reasons why we chose the CM when we started, and we really haven't deviated from that because it's worked well. We haven't had a reason to change this pathway for these patients, and that doesn't mean it's the only way to do it or this is the best way, but we really haven't had a reason to deviate in our own cohorts. So we know the centromedian nucleus participates early in the propagation of generalized seizures. That's been shown in fMRI studies and studies where DBS speeds are externalized, going back to the Velascos in the 80s and the group at King's College and London have shown this too more recently. Tractography studies demonstrate the broad connectivity, not just to the cortex, but also to the brainstem, which may be a more privileged connection that the centromedian nucleus has. And the CM is particularly well connected with the motor network. I have a slide to describe that in a couple minutes. And then why would we start with RNS instead of DBS? There are a few reasons for that. First is the objective data. So the rest of the way we do epilepsy surgery and follow outcomes, and certainly with neuromodulation, is trial by error and waiting for the patient to respond and let us know what's happening. This device gives us objective data that we can use to track how the person's doing. We can personalize this to their own brain recordings. We think maybe this results in less potential for cognitive side effects because we can try to avoid things like stimulating sleep spindles, doing a lot of simulation at night that might have an effect on memory consolidation, or because we're delivering less simulation overall, there's a longer battery life. One can follow the recordings for medical management. You can identify patient seizure cycles, and it gives also an opportunity to interact more with the patient. We're discussing their own brain data. Briefly, some other background. So these are the first two case reports, one in adult and one in kids using this technique. And I'll just say this first report had 2 years follow-up, and that was in 2020. So we've been doing this since about 2017. I think so now several years experience with this. This is something important to note, which as far as I'm concerned, is essentially a settled fact and really had been in the literature before we did this, that if a patient has idiopathic generalized epilepsy, of which there are, a few different flavors, but all these patients, you can essentially know for a fact that you can detect generalized spike wave discharges in the thalamus if you put an electrode in there that can record, including the RNS. So this is a panel showing scalp EEG recordings, simultaneous recordings from the RNS device. And you can see that these spike wave discharges have the same spectral content. So this is the time frequency representation of the time series data here. And you can see it looks pretty similar because it's the same thing. And this goes back to the idea that the thalamus is really part of the origin of the seizure. It's required for the cortical synchronization probably in idiopathic generalized epilepsies. All right, and then this was a case series of some other follow-up data. And I just put this in here to point out that in terms of patient selection, patients with majority absence seizures will do very well, and those with generalized tonic-clonic seizures will also do well. And so a lot of the outcome here is related to, this isn't curative, so the seizures don't stop, but you can take patients who previously were going to the emergency room several times a year, often being intubated for their seizures, which are generalizing, and convert them to patients who do not lose consciousness during their seizures, and seizures can become more brief and less severe. I just want to mention that in the United States, there's now this pivotal trial, which has actually finished its initial enrollment and is trying to enroll several other patients because of demand to enroll in the trial. It has a really unique endpoint, which is the time to second generalized seizure. So once a patient has a second generalized seizure, they're turned on. They're still not told whether they were on or off, but I think this is a unique design that helps to make this safer for patients. They're not waiting to be turned on. Okay, so let's get into the nuts and bolts of this. How have we targeted the central median region? So what you're seeing here is our current in blue and historic, which is the first several patients that we did in Pittsburgh, are yellow. And the reason there are two different groups here is because if you just use the Schaltenbrand Atlas coordinates for the central median, which are roughly 10 lateral at the level of the PC in the Z plane and the posterior plane, you end up, based on modern thalamic atlases, kind of skiving the CM in many cases. Now, the interesting thing is that targeting worked very well for the first several patients we did, but nonetheless, that wasn't the intended target. And so when we realized, using the tools of lead DBS, which is how we do our lead reconstructions, that we weren't always in the CM, I changed the targeting, and we have not been able to tell a difference in the results. We're working on, defining that to be more certain about it and try to have a better understanding of how localization relates to outcome and how this might be different in different IgE subtypes. We're not there yet, but I'll just say that this probably indicates that there's a region that can produce effective results, and that it's not always the CM, because sometimes, so the way that we set the RNS parameters is that we look for the electrode pair that has the highest signal, and you're going to record on two bipolar pairs. And often it's superior to the central median. It's something up in here in the area of even VPL. That's the area that has the highest amplitude of seizures. That's where we turn on the detector, and that's where we stimulate. So it's something about this region, the connections, that is key, as opposed to the central median itself. That's our current take on this. Nonetheless, we still try to put the electrodes in the CM. And the other way that we were aided in doing this, and this is the way that we target the CM now, it's really based on this work by the Melbourne group, and Aaron Warren's the first author on this paper that came out now a few years ago, where they use some fancy techniques to make an MP2 RAGE sequence look better, and kind of create their own atlas. And you can do this at your own institution, not this well, at least we can't, but we do have an MP2 RAGE set up to delineate the central median nucleus. And you can see it situated here between the medial dorsal nucleus and the pulvinar. Out laterally is the VPL. Here's a reconstruction of one of the lead trajectories. You can see the CM in yellow. Right below it's a parafascicular nucleus. It's really an open question, again, whether this is important to cover. Again, a lot of our stimulation has ended up out here, even in the ventrolateral regions. Now, the one thing, of course, to be aware of here is that you can get side effects from stimulation, sensory side effects. This, depending on the trajectory, stimulation field may not be too far away from VIM, the ventral caudalis nucleus. So it is possible to get sensory side effects. It's also almost always possible to change the programming parameters to get around those. But this is a current way that we think about doing the targeting. And that's, again, based on the figures in this paper, that where the way I've interpreted this is the best view of the centromedian is in the axial plane, it's 3 millimeters superior to the PC, and the coronal view about 6 millimeters anterior. So you can see that here. And again, our images don't look quite this nice. So but the goal is to have the electrode coming through the center of the CM in this plane. So the way we try to accomplish this now, so we have two different techniques depending on OR availability, frankly, and sometimes some other factors, whether we do this. And we do all these cases under general anesthesia. In some groups and most of the patients, we use the ROSA as our stereotactic apparatus, and more recently we've been using the ClearPoint device and MRI. So these are the standard kind of indirect coordinates that I use now, just to make this easier to start, which is 8 millimeters lateral, and this is to the mid commissural point, and now 11 millimeters posterior. If I given this presentation a year ago, I would have said 9, and then we found it really in the anterior part of the nucleus, which didn't make as much sense given our previous history of being more posterior with the Schaltenbrand analysis. So we started burning in the target, which I'll show you in a minute, and then I've gradually moved these back posterior, usually a couple millimeters, at least in terms of where we start. So then we slide up on the trajectory to this plane, again, 3 millimeters above the ACPC line. I'm sorry, 3 millimeters. Yeah, 3 millimeters. This is 3 millimeters above the PC, 3 millimeters above the PC. So we're just scrolling up on the target trajectory and then looking to see where we are. And here's the coronal view where this looks pretty centered. This, again, is one of our earlier ones. I need to probably go back and get a different one, but I'll just point out this looks a little anterior. Here's the centromedian. So this is probably one that should be a little posterior if you really want it to go right through the middle. Okay, so that's delineated here. Show what this looks like with a burned-in target. So using some of the tools from Lead DBS, and if any of you in your group have an interest in learning how to do this, I can't personally do it, but some of our residents and those in the lab can do. Be happy to share with you how to do this using some of the toolbox from Lead DBS. We can burn in the centromedian nucleus, and so if it's a little fuzzy on the particular scan you have, you can burn it in, and you shouldn't take that as the ground truth because that's a transformed Atlas based ROI, but it can help you to tune it, zero in on the target. And so that's what we're doing in the cases now as a double check. Okay, so we can also do this in ClearPoint with the ClearPoint software. So in our MRIS, which is where we do the ClearPoint, we cannot obtain an MP2 rage. It's not available on the scanner, so we use an F-gator. An F-gator can work very well, just the intensities are flipped. So on the MP2 rage, you're looking for the bright signal, and on the F-gator, you're looking for the dark signal. You really should have an image that doesn't have the trajectory here, but I think you get a sense of it here. Here's the inline view, and you can see this part of the target here. See, we're coming through the centromedian here and here. And then we can also burn in the CM in the ClearPoint software as well, and use that as one of the images in the ClearPoint. So you can see how we're just simply trying to come through the center of it. Put the bottom of the deepest contact is at the PC equals 0 level. And I haven't, again, that could be there's a way to improve this, but I haven't come up with a rationale of why we should deviate from that. And so to make it simpler, I just implanted it at Z = 0. All right, so this is what our, to talk about, kind of a few tricks of the trade here. This is what our ROSA setup looks like. So we have the patient positioned supine, flex the neck forward to get access to the back of the head. I just use 2 incisions like I would for DBS. The electrodes are implanted first, because then we'll come back and make a separate craniotomy for the RNS. And we implant the electrodes first so that there's no brain shift. If someone were to inadvertently open the dura, let's say doing craniotomy, we could have some brain shift that we obviously is could be detrimental to the targeting. We use not a twist drill, but something similar, small striker drill to make a small opening. And with the ROSA, because you have to have, at least in our setup, we use the microdrive as the DBS holder. So we'll take the drill guide, just like we're doing SEG. We'll make our 2 small craniotomies. We'll initially, our burr holes, twist drill burr holes, we'll fill those with TIS-seal in case we open the dura so they don't have brain shift. Then we'll switch out the adapter on the ROSA, and we'll have the electrodes ready to go actually before we even do the drilling, so that as we switch out quickly to the microdrive, which is our DBS, or this is RNS lead holder, we have everything ready to go. We'll bring that in, and we'll drop in both leads, and we'll secure them with a dog bone and a screw, because you can also use a DBS type stem lock, which we've done. The reason is the RNS locking device itself, it actually doesn't have a lock, and it's pretty futzy. So I think it's better to just use a dog bone and mark this, or use one of the DBS locks. Then we'll do the craniotomy and attach everything. This is a pediatric patient, so I'll just mention that we have been doing a lot of RNS in kids for both generalized and primarily generalized, or IgE cases, and symptomatic generalized. The device is 3 millimeters deep. So we've done this in kids as young as 6. This is a 10-year-old boy, and it just shows the relationship of the device and the size. And you can see the young skull accommodates this really well. Again, just an example of the positioning and how we would do the incision. And this is from the side, and this is from the top, and I have probably a couple other views of how we do this. But this is all done in one sitting in the same position. And we just sit down as we do the posterior incision for the craniotomy. Now, this is an example of using the clear point. And to do this most effectively with the clear point in one sitting, it's best to use this frame called the inflection frame, which can flex and also rotate. And then you do this type of asymmetrical penning. And I think this is maybe the second case. So the first time we did this, we thought, oh, this worked great. And let's put all the cases into the IMRIS and do it this way. And then I made a mistake and planned this craniotomy too low. So I'll show you a different picture in a second, but you can see how, you can't really see this. But the idea is, when you do the RNS implantation, same way you would do a sleep DBS in the IMRIS with the clear point or in your diagnostic scanner. And then at the end of that case, you simply bring the patient out and you turn the frame so that you have access to the back of the head. This is too low. Basically, this was very painful. So if you have the option to use this technique and you want to try it, don't do this. You want to plan this out a little higher. You can see how much higher this is, and still, this is kind of our normal type positioning. You can see the difference here is this other patient didn't really flex the neck either, so that was a mistake. But this one we did. We remembered that we should do that, and we flexed the neck, and we got this up. And this is actually quite easy. It's a really nice setup, as long as you do the positioning and plan the incisions correctly. All right, and then that gives us, this just shows you at the end where, the magnet's away and the head's turned. You have easy access. This is the telemetry device that's positioned right over the IPG, and you can see we have easy access to that. This is Nathan Sisterson, who's written a lot of RNS papers for us. This was, I think, one of his first RNS cases as a resident. Okay, so to mention a couple other things about surgical workflow, talked about the direct targeting. We don't use microelectrode recording. So I think in the first or second case I did, again, back in Pittsburgh, I did do microelectrode recording to see if that was helpful. I didn't find it to be particularly helpful. That could be for a number of reasons, but it also matched my interpretation of the Warren et al. Paper, where they do report their microelectrode recording techniques. And my take on that is that they didn't find that particularly helpful either. We don't use cortical evoke potentials, which is an interesting strategy. I've never, aside from just studying it outright to figure out what to do in terms of practical clinical workflow, I'm not aware of a rationale for how that would direct how we might change the positioning of the electrode, or what we would do if we didn't see a cortical evoke potential, and would we use subdural ECOG electrodes, or would we use scalp EEG, and is it worth it to do all that? And so far this has worked very well based on the direct targeting, so I haven't seen a need to use cortical evoke potentials. That doesn't mean that someone might not come up with a better way to do this in the future. It's certainly a possibility. We do place both the leads before we make the craniotomy. I've said that. And then we always get a post-op CT and check the accuracy before the patient's discharged. All right, I'm running short on time at this point. Let me go quickly through this one case, which this goes beyond primary generalized epilepsy, but it illustrates certainly the way we're doing things now for these multifocal, rapidly generalizing cases. So this is another group of patients that otherwise typically weren't candidates for surgical resection, or you might do an SEEG and define some region and do a big craniotomy and resection with unsatisfactory seizure result long-term, and at the end of the day, and maybe not the greatest cognitive effect for the patient. So I'll just take you through this real quickly. This is a 31-year-old guy, polymicrogyria. He's had it almost for his entire life. He does have some elementary motor features in his semiology. He has generalized spike and wave discharges. There's some lead in from one side. The MRI shows malformations of cortical development essentially all over. The PET has some abnormal uptake associated with some of these regions. We didn't get a MEG, and he has developmental delay. So based on this information, we have a hypothesis that there's a multi-lobar problem. But maybe it's primarily frontal based on some of the semiology. And the potential treatment options are resection or ablation of maybe one of these nodes of the network, which is most involved, or a cortical RNS. Again, if we can define the regions are really cortical, but because of spike wave discharges, we're thinking, well, this probably involves the thalamus. So maybe we'll do thalamocortical if this is just one side, or possibly we do bilateral thalamic RNS if it's really both sides. So we planned for a bilateral frontal parietal SEEG that included targeting the centromedian nucleus. And this is, so let me just mention this quickly. So we're using SEEG to inform our decisions for RNS because of the reasons I just mentioned. So without doing SEEG in these locations, we feel like we'd be taking too much of a guess about where to put the device, because we have to make a decision about where are we going to detect the seizure and where we're going to stimulate. And that might not always be the same place that we do that. And so we have a very simple way of thinking about this now, just based on the latency of when the seizure is detected in the thalamus. And if it's detected at the same time, or very close to when the seizure is detected in the cortex, then we know we can use the thalamus as a trigger, and that probably stimulating there is going to have an effect, in the connected cortical regions, as evidenced by the fact that the seizures are starting cortically or passing through that region of the thalamus, almost instantaneously. So this is just a couple screenshots from that implantation. In this case, we went through malformations that looked particularly offending and had the same trajectory as we would eventually implant the CM lead. This is an illustration of why the centromedian, I think, is good for these epilepsies that certainly where there's loss of consciousness because of the connection to the brainstem. And it really seems to have a probably better connection. This is parcellation of the ANT in red, the CM in blue, and the pulvinar in yellow. And these are the three regions or targets that we think about when we're implanting SEEG and thinking about the RNS strategy. This is the SEEG result. So low voltage, high frequency activity, and essentially across the cortex, but really simultaneously picked up in the centromedian nucleus and on both sides. You see that here. You can see how the seizure evolves there in the thalamus as it does with the cortex. And so, so the patient got bilateral central median RNS, significant improvement in quality of life, rarely losing consciousness. This is what the electrode reconstruction looks like. We still tend to be now he's been implanted a couple of years, so if anything, it may have moved this back, a little bit. And just pointing out again, this is VPL in red. So, and sometimes it's very interesting. We'll pick up the seizure and stimulate here without any side effects. And sometimes we have to work on the parameters a little bit to avoid the side effects. And just quickly, so this is unpublished data. This is how I've been using bilateral centromedian. And we kind of did a data cut several months ago. We're using across IgE and multifocal cases, and it's working pretty well. It's a mean seizure frequency reduction. It does can take almost a year in many patients. And so that's it. I do want to thank our patients who have, I should mention, this is off label that we've done most of these cases, and this requires obviously informing the patient about what you're doing and why it's new. And the patients, put a lot of trust in us to try these newer techniques. This is Emily Kalina, who went back to work as a graphic artist after getting her bilateral CM RNS for IgE. And she wrote a blog about this. If you're interested, you can look at it there. Okay, thanks very much. I hope I didn't take up too much time.
Yeah, thank you very much, Mark. We will move on directly to Arthur's talk. Arthur?
Yeah, just joining. Here. Okay, can you see it?
Yes.
Okay, perfect. Thank you so much, Mark, for this exciting presentation. I think I'm left with everything but RNS, right, for generalized epilepsy, and this is what I intend to do. So most of the patients with generalized epilepsy are really not good candidates for cortical resection, and surgical procedures in these patients aim to reduce the seizure burden, including SUDEP, but unlikely to make these patients seizure-free. And that's why, since they are not good candidates for resections and etc., we don't perform SEG in any of these patients. Surgical procedures might be disconnective or neuromodulatory, and among the diverse generalized epileptic syndrome, maybe a good prototype would be Lennox-Gastaut patients, which are usually refractory and might be a more homogeneous cohort for judging this procedure. So what are the competing procedures? We just heard of RNS, which probably have very good results. As Mark mentioned, there are ongoing clinical trials regarding this, but I don't think we already have the published results, but very promising. But other than that, we have callosotomy, VNS, and centromedian DBS. Callosotomy likely being the most underperformed procedures of all these ones, and VNS being the more overperformed procedure of this all. I'm just gonna briefly touch on the technical issues of each of the procedure. I know that this might be not new for many of you, but there are some difference in technical issues in each center. So let's start with callosotomy. What we basically do is a parasagittal craniotomy, a third behind the coronal suture and 2/3 above in front of the coronal sutures. As you can see, we don't use any type of retraction. We don't use lumbar drain, nothing. And you just dissect without any retraction the mesial frontal lobes, and you start by dissecting the corpus callosum. You can use the bipolar under low settings to simply dissect the corpus callosum. In the most anterior part of it, you have to see the ascending anterior arteries, anterior cerebral arteries. So this is your main landmark that you're just in most anterior part of your rostrum, and then you go down to the in the direction of the anterior commissure and the septal area. For any of you that tried, this is the ascending anterior cerebral artery. So for those of you who try to film callosotomies, it's very difficult in the beginning because everything is white, but then you can, from where you proceed with the with this surgery, it's easier because you get the ependyma, and this will give you some contrast. You see, using the bipolar just to dissect low settings, to dissect the corpus callosum. We try not to invade the ependyma. Is not a big issue if you do that, but we try not to do it, not to open it, not to open the ventricle, because if even small amounts of blood that will come in, it's going to give headache to your patient in the post-op, and you wouldn't like to do that. You see the ependyma and you stop when you see the ependyma. The first anterior half of the corpus callosum you do with direct visualization, and then when you come to the posterior part of the corpus callosum, you do it with intracallosal suction, and you follow it back, and there is a point when a typical callosal anatomy, when it gets thinner, and this is immediately in front of the splenium, and then this is the part of it get thinner, and then it get again thicker, and this is the splenium itself, and you're going to see the posterior cingulate region, and that where you're going to stop your dissection of the corpus callosum, and this is the cingulate, the posterior cingulate. You see there. See a kind of a intracallosal suction, and this is very effective and very simple. You don't have to dissect the whole interhemispheric suture to do that. The other procedure is VNS, probably very well known. I'm just gonna show you how we are used to do. Please pay attention that we are not put any laces in the vagus nerve. We don't stretch the nerve. We always try to keep an epineuro intact. If you just dissect everything around the nerve, you're dissecting the epineuron out, and you're probably going to kill at least part of the nerve. So the suggestion would be not to put laces and stretch the nerves, and just pull the nerve as gently as you can. This is the carotid artery being shown there, and then you have the jugular vein there, and obviously the nerve. And just the nerve has, the electrode has these three components. One is just fixation, and the other ones are the anode and the cathode. I'm not gonna show you the whole video, but just one of them being fixed, and this is repeated to the other one. It's a kind of a very simple procedure, fast, and the patient can be discharged the same day if needed. The most important thing here is to keep the nerve intact. We are stimulating the nerve, so if you just peel off all the epineuron and you stretch the nerve and you have neuropraxia, your results might be not as good if otherwise. The other one is central median DBS, which shares many concepts with what Mark had already presented. This is what I'm going to be showing is the targeting based on proportional systems, atlases. And then I'm going to show you how we target today. But when we started to use this one,
describes the techniques for targeting the three most widely used structures in neuromodulation to treat refractory epilepsy. Our next target is the...
And by the way, the voice is from Tatiana, she put that together when she was with us for a couple of months.
Central median nucleus, which is a thalamic nucleus of the intralaminar group. As it is not directly visualized on the MRI, it is necessary to identify the anterior and posterior commissures in order to define the target. After fusing the T1 sequence with the stereotatic CT, the anterior commissure is visualized on the anterior wall of the third ventricle and the posterior commissure right above the aqueductus. It is also necessary to choose a midline point to correct the alignment of the images. The central median nucleus is located 10 millimeters lateral from the posterior commissure, at the level of the anterior commissure and the posterior commissure line. Once again, the burr hole for entering the cortex is placed 1.5 to 3 centimeters lateral from the midline and 1 centimeter in front of the coronal suture, but adjustments may be needed to avoid superficial and deep sulci and major vascular structures. Therefore, after defining the entry point, it is necessary to ensure no major vessel is crossed along the trajectory. This video.
So this being said, over the last at least 5 years, we are using combine this type of targeting to the imaging, image-based targeting, as Mark has already mentioned. We do use MP2-RAGE acquisitions, and MP2-RAGE is, I'm not sure why, but we are only able to get good ones on Siemens machines, and we do need to write a specific patch of software to get them. So it's not something that is readily available in all machines. The MP2-RAGE has 2 echoes. The second echo is a MP-RAGE type of thing, and the first echo is the echo that we use to target and you can see this is one of our intra surgical images. You can see the centromedial and the angle of the medial dorsal and the pulvinar. In fact, we aim at the bottom of the nucleus, not at the center of the nucleus, and the idea is to trespass the nucleus because we plan for bipolar stimulation, and then we want one contact at the bottom or immediately below, and the superior contact immediately above the nucleus. So let's have a look on what we know about the outcomes of these procedures, because this will impact in our rationale how to use them. So these are the seizure-free rates for these procedures. They're not high enough. I guess maybe Mark could forward us more information, but we don't have right now reliable information on that. But you see from the other ones, the seizure-free rates are pretty low. They all are shown to reduce SUDEP rates, apparently related to the decrease of the seizure frequency and burden. And all procedures were apparently able to increase the tension, some related and some unrelated to the seizure frequency decrease, although this effect was not adequately quantified due to the cognitive impairment in most of these patients with idiopathic generalized epilepsy, especially kids. So taking this into consideration before we enter the cases, there is then a rationale for using more than one procedure in patient, since none of these procedures are expected to render the patient seizure-free, and this might include combining a disconnective procedure and neuromodulation, or combining 2 neuromodulation techniques. Every center has his workflow for patients with epilepsy, but I'm not going to discuss this, but just to mention that people with generalized epilepsy most often skip all this very offensive localizing tools that we have for focal epilepsy, and then go to what we call palliative procedure like VNS, DBS, and callosotomy or RNS. And then I just maybe want to start a discussion of using this word palliative, because this is borrowed from terminal patients and cancer patients, and this is probably not a good word for the procedures we are doing. Maybe you could help me in finding a better word for palliative, but I think it's urgently needed. We have emphasis on the pediatric population, where idiopathic generalized epilepsy is more frequently referred, frequently refractory. There are different causes. The anti-seizure medication had deleterious effect, and there's functional plasticity that can help us. So let's go to a first case. This patient had West syndrome, and which evolved to Lennox-Gastaut syndrome. And this is his EEG, is very typical of a Lennox-Gastaut type of thing. The main seizure type is atonic, and as we are going to see, it's a kind of I would say a consensus, but it's highly a consensus, almost a consensus, that this single procedure that's more effective for atonic seizures is callosotomy, and this can be seen in a different way. But this I put this one for Mike because this is probably the only published manuscript that showed that corpus callosotomy and VNS has the same outcome for atonic seizures. All the other literature has provided data showing that callosotomy is superior to all the other procedures in patients with the prevailing type of seizure is atonic. This can be seen also here, coming from Ed, and actually this is a systematic review, and there is also another meta-analysis that shows actually the same thing. This is another one, a meta-analysis coming from George in Canada, showing exactly the same thing, that atonic seizures are better treated with callosotomy. And this is our single institution comparison, direct comparison of VNS and callosotomy, showing exactly the same thing, that the atonic seizure better responded to callosotomy than for VNS. So our idea for this patient with Lennox-Gastaut, who had prevailing atonic seizures, would be callosotomy, right? The question is that he has callosoagenesis, and this brings us the idea that you have to use different techniques in different patients according to what they have. You have to customize your treatment. So callosotomy here would not be a major player because there is no callosotomy, and this leads us to a quite well-known negative biomarker for corpus callosotomy. It means the thin corpus callosum. Of course, a genetic corpus callosum is not in the discussion, but even if you have this very thin that you see in the left side, this is not a good biomarker for a good outcome. So you should not do this type of patients using callosotomy. So what are the responses from the other procedures that we know? So this is the response of this type of patients to VNS, 80% of responders. The problem with VNS is that we don't know much about it. We know much more about RNS, for instance, that it's a much newer procedure than we know about vagus nerve stimulation. Clinical variables do not predict response. Electrophysiological activity, structural finding, and systemic biomarkers were not reliable biomarkers either. And there are some intent to use network-based biomarkers, but they are still being developed and not ready for direct clinical application. So we don't know much about vagus nerve stimulation. There are some predictors for good outcome using VNS, and this is basically a pediatric population with generalized epilepsy and shorter disease duration, but let us take into account this is very low level evidence. And central median DBS is also 80% of responders, but it's more effective than VNS. The amount of responders is it's the same, but the seizure frequency reduction is much bigger in central median, and it's earlier than what you see in VNS. More recently, we were exploring the biomarkers for central median stimulation, and were able to show that central median stimulation indeed was able to alter the band frequency in the scalp, especially regarding the increase in the gamma frequency and the decrease in the alpha frequency. This was done together with the Yale House Blumenfeld lab. And more recently, this is not published yet, but it's going to be presented in the ESS in Orlando soon. Although there is no, it was not statistically significant, it was very clear that if patients had an acute 50% reduction in spike frequency during naive stimulation, before starting programming, these were the people that responded better to central median DBS. These findings were also replicated by Bob, exactly basically the same that what I have mentioned. And there is the STEL trial coming from Australia, where they use intermittent, we use continuous, they used intermittent, and they were also able to show that central median DBS was able to decrease the laterographic seizures, though they are not able to show that they decrease the clinical seizures, meaning that they were lucky to include the EEG data, because otherwise their study would be a negative one. And this is Mark's, just to mention that there is ongoing work on RNS, and he had just shown us 20 patients, multifocal and generalized, which is great, and we are looking forward to the results. I'm just wanna show this one, and that's why we use central median stimulation, and that's why we are going to be maybe using multi-site thalamic stimulation. This you see here, CL activity during discharge. It's basically inhibited while the anterior nucleus of the thalamus is excited. So the different thalamic nuclei are responding in a different way. So multi-site thalamic stimulation is probably going to be a reality in the future. So back to our patient. So no callosotomy, and he went on to central median DBS with 60% reduction of the atonic seizure. So this is another one with very likely the same type of image. I didn't see the Mark's patient's image, but very similar to what he was mentioning, with bilateral perceive extensive bilateral perceive heterotopia behaving as a generalized epilepsy patient. And this one has a very specific type of seizure. It's eating epilepsy and hot water reflex epilepsy. They're very well known, although rare, type of reflex seizures. And this one could go either to, you know, all the procedures mentioned, but this one went specifically to VNS due to the eating reflex seizures, because the eating reflex seizure takes an income of information from the abdomen to trigger the seizures, and the VNS is likely gonna, due to a nodal effect, block this activity. So, and this is why this patient, we use VNS instead of the others with very good results, specifically related to the eating reflex seizures. Just move very quickly to other patients who bear genetic abnormalities. It doesn't mean that because they have genetic abnormalities that you don't have to treat them, and it doesn't mean that neuromodulation or other procedures could not help them. So this is SCN8A, that we have a bunch of these patients, likely because of Christine's draining this type of patients to the clinic. But it appears that SN8A is specifically a syndrome that responds very well to VNS. We have very good result of VNS in this type of syndrome. Although, of course, it's very rare, so there are no comparative studies, but they start with very, very complicated and severe epilepsy. So VNS is probably a good option for them. This is the baby when we started seeing him, and now he's, you know, it's not, of course, it's not a complete normal kid, but is doing quite well under VNS. This is another type of genetic epilepsy, Angelman syndrome. It often presents as generalized epilepsy, and this kid has atonic seizures, so he was first submitted to callosotomy with improvement of atonic seizure. But then the main remaining seizure type was absences, and then what should we do with this patient. He was submitted to VNS and got 55% reduction in seizure absences. Although, to be honest, probably if we are going to be doing this today, we'll probably go for central median stimulation in this kid. So just to summarize the impact of genomics on choosing these procedures, again, the fact that the genetic basis has been defined in a specific patient, that doesn't mean that this patient is not supposed to be treated as indicated. No specific genes has so far been clearly associated with a better response to any neuromodulatory procedure, but this is ongoing, and we are also going to be presenting something on this on the IESS in Orlando. Genetics clearly delineate patient population that are not good candidates for resections, for instance. And of course, these sodium channel blockers and etc. are not good candidates for resections. So we just need to insist on doing resections for this type of patients. And there is emerging evidence that some canalopathies will respond better to neuromodulation or specific drugs, as I mentioned, to SCN8 a patient. This is just to keep us humble, and this is something that I like on in medicine, and especially in neurosurgery. This is a patient who had a West syndrome evolving to Lennox-Gastaut syndrome. The initial main seizure type was atonic, and other seizures were absences and tonic-clonic seizures. He underwent callosotomy with 90% of reductions in atonic seizures, and the main remaining seizure types of atonic absence seizures and generalized tonic-clonic seizures. He underwent VNS. He was not a responder to VNS. And then the main seizure types remain atypical absence and tonic-clonic seizure patients. And of course, the last resort will be central median DBS. And you would expect me to tell you that it has a wonderful result with central median DBS. And indeed, he did. He was seizure-free after median DBS, but the generator was off. We implanted him, and he never had a seizure again, just to keep us humble. Just to bring very briefly in 2 or more minutes the discussion in the direction that Mark already mentioned on thinking on multifocal patients as if generalized. In fact, this is a patient who had a 9-year-old right-handed boy, seizures since the age of 6 years after encephalitis. Encephalitis is a very bad etiology for focal epilepsy. They are usually multifocal or generalized. And he had this focal impaired awareness seizures with head rotation, either to left or right. This is usually bad information from the family, but it's not in this case. And he had multiple seizures and a low IQ of 75. MRI showed mild to diffuse atrophy, no focal abnormalities. Interictal SPECT is normal. It's not a good examination for this. And PET was normal, which is not a great examination for this too. Interictal EEG showed bilateral independent frontotemporal discharges prevailing over the left hemisphere with secondary bilateral synchrony, very clear. And ictal EEG showed bilateral independent frontotemporal onset with contralateral head version and posturing. So this is the interictal, is truly multifocal. You cannot expect to find a single focus in such a patient. And this is the ictal. You clearly see in the left a seizure coming from the left, and then the other seizure to the right coming from the right. And this is just to show you how clearly independent they were. So this one, to look at the rotation, the rotation and the posturing was to the right, and the same patient a couple of hours ago, afterwards, a clear left version and posturing to the. So this is really multifocal bilateral kind of patients. So in a seizure conference, you can ask every type of questions like this, of what we can do and what you cannot do with these patients. Of course, I'm not going to go over all of them. And the treatment options all on the table would be this. So we started with this. This was when we first treated him. He was quite a long year ago. So we started VNS. That was the only thing available other than callosotomy. And he was non-responders. So since this was a frontotemporal epilepsy, maybe ANT DBS would be a good option for him. bilateral ANT-DBS, and this is what happened when we perform ANT-DBS. So he was not a responder for ANT-DBS, and the final option will be central median DBS, which resulted in a marked decrease in seizure frequency and attention improvement. So it's probably true that we can tackle these patients with multifocal epilepsy as we do with the generalized one. Just to finalize and mention that the combined therapy is also on the table. This could be combined surgical callosotomy, VNS after callosotomy, which is more, let's say, frequent because callosotomy was there before, but more recently there are some series suggesting that people already submitted to VNS can go back and have callosotomy with good result, especially the more recent one by Jonathan with a multi-center cohort that showed that callosotomy after VNS gives a good result. And again, you can also have central median after callosotomy. We are combining here callosotomy with neuromodulation. This is our results. And then you can have combined neuromodulation, use both VNS and DBS or whatever. And this is probably going to be something that we are going to be doing in the future. And we have just published on the high efficacy of adding central median DBS to patients using VNS. With that, sorry for getting a little bit long. I'd like to thank you so much for having me here and looking forward to the discussion. Thank you.
Thank you very much, Arthur. And also Mark for 2 excellent talks. There are many things to discuss, I guess. And maybe I'm going to start with one question to you, Arthur. In the beginning of your talk, you said you think that callosotomy is underrepresented and VNS is overperformed. What do you think are the main reasons for that?
Well, I suppose that one of the main reasons is VNS is such an easy surgical procedure. It's extracranial, so you don't have any, you cannot foresee any intracranial or neurological side effect. And this is actually being done by non-neurosurgeons all over the world. So it's sometimes it's just because it's there. You see, you have 150,000 patients implanted with VNS. You'll never have 150,000 patients submitted to callosotomy or RNS,
right,
or DBS, because it's technically demanding, and it does it will never be comparable for neurological side effects VNS to anything else intracranial, because it's always extracranial. The danger here is for people who start using and promoting and etc. Procedures that are less invasive but are less effective too. So, but we are in a very interesting era of patient customer preference, right? So probably something related to that. I don't know if it's added something or just generated more trouble.
And would you think that now in the era of LIT, this will change a bit towards, callosotomy procedures, because it's then called minimal invasive, and the children or people can go home the day after surgery as well? What do you think for the future?
I think it might have a similar impact on how LIT had on temporal lobe patients, because there are a significant amount of patients, especially in the US where LIT was more used, that would not be willing to undergo conventional resection because they have to, let's say, open their heads, but would be willing to undergo LIT, for instance. So it might have the same type of impact of patient preference, with the likely same results in terms of efficacy, because now we know that LIT efficacy is not superior; it's actually lower than conventional microsurgical cortical amygdala appendectomy. And in callosotomy is probably going to be the same, because you're going to leave some islands of corpus callosum if you do a steroid. There some people had already played with stereotactic callosotomy using radio frequencies. So this is not exactly new. But then there comes a discussion, well, why the patient who tells you, well, I prefer to do 2 leads instead of 1 microsurgical resection. So, you know, this is something that we are going to be seeing in the future, I guess.
And in your experience, if you have a patient with atonic seizures, I guess callosotomy comes first, and if this is not working well, then VNS and then DBS. So what is your algorithm for these kind of patients right now?
In our center, we always start callosotomy, as you mentioned. It's very clear for us. Microsurgical callosotomy, it takes 1.5 to 2 hours to do. Lead callosotomy is much longer than this. But anyway, we start with callosotomy. This could be microsurgical, or if you are a fan, you can do lead callosotomy or wherever you, as far as you disconnect, as far as you cut the corpus callosum. And we prefer to go to centromedian DBS. And why not RNS if they were able to prove that it's the same result as continuous centromedian DBS. And we leave VNS for, maybe a last resort.
Okay. Yes, please, Guy.
Yeah, just while you're on the callosotomy topic for both Arthur and for Mark, thoughts on different approaches for subsectioning of parts of the callosum, anterior 2/3 versus complete, posterior versus anterior approach to get to the posterior callosotomy. Can you comment on are you always doing complete callosotomies, and if not, when do you not?
Do it a go, Mark. Otherwise, I'm going to hijack the discussion.
Okay. Yeah. I'll just mention a couple of things. So I also do not use lit for callosotomy for the reasons that you mentioned. It just hasn't made sense to me to do that. In terms of the algorithm, we've had one patient where we tried to treat the atonic component with RNS. It was after I did an anterior 2/3 callosotomy where the patient's atonic seizures didn't stop. And they also had other seizure types. They were reticent to go back for a completion. So we did RNS, which may have helped with the other seizure types, didn't help with the atonic component, which did stop when I completed the callosotomy. I used a different, I put the patient lateral, with the head tilted up to use gravity. I also don't use retraction, as Arthur mentioned. And then I think a similar technique. But I will say that our strategy generally, we don't do a lot of callosotomies, but is to go for the posterior disconnection first if the main goal is to stop the atonic component based on the literature that supports that. I think the patients are, do have a little bit more of a disconnection syndrome potentially, but I'm interested in Arthur's take on that too, whether or not to start with the posterior, anterior. But otherwise, I think the techniques are similar, and in the anterior, the tricky part I find is getting around all the way to the anterior commissure to make sure that it's completely disconnected, which you do basically just microscope angles. But Arthur, what's your take on that?
Well, at the beginning, we did all types of lengths of corpus callosotomy, and anterior, then 2/3, then half, anterior, half, 2/3, and complete. But we ended with using only complete callosotomy. We don't. It's very difficult for us to understand the use of any other more restricted callosotomy. These patients had widespread, very widespread epileptic discharges. They are most often not prevailing in the posterior area. Most of them prevails in the anterior area. There is clear predominance on the posterior to anterior flow of epileptic activity intrahemisphérically. So it's more likely that the posterior epileptic discharges will go anterior than the other way around. So, and just using the posterior part of it would not impede the intrahemispheric projection anteriorly and the bilateral synchrony that you have in front. So it's just depending on the kind of patients that you're dealing with. If you're dealing with a patient with posterior polymicrogyra, then you can do probably posterior. But if you're doing a Lennox-Gastaut case, I don't think it's enough. In our series, was not enough, and we basically offer only complete callosotomy. It's true that in some adults, the curvature of the corpus callosum and do not allow to do the whole of the splenium in the single procedure, then you leave a small piece of splenium there. But in kids, it's very easy to do it. So basically, we offer only complete callosotomy.
Mm-hmm. And could both of you comment on how the thickness of the corpus callosum is influencing your decision making? So is there a cutoff value that you're using, or is it just if it's thin, then you're not considering at all, or how is it impacting your decision making? Mark, is it at any time, is it influenced? Do you look at it, or is it not a biomarker for you?
Well, I think only agenesis would be the main influencer. I think otherwise, if it's there, it's probably functional, even if it's thin.
Okay. Arthur, how about you?
Yeah, we strongly feel that callosotomy is a disconnective procedure. If you don't have what to disconnect, then it's probably not going to be very useful. And the first thing you see when the corpus callosum is getting thin, you lose this indentation, this parietal indentation in the posterior area, because the corpus callosum comes and then it gets thinner and then thicker again to do the splenium. So the first thing you see is that it disappears, so everything is thin. And the second thing that you see is that it gets more curved than a regular corpus callosum. So they are more curved, and they make this more difficult, for instance, for LIT or any radiofrequency callosotomy, because you have to do more penetrations, because instead of the corpus callosum being like this, it's curved. It's almost a semicircle. The one I showed you is almost a semicircle, and to do a semicircle with a stereotactic procedure is much more different. The other question is, when thin is thin? That's a good question. It cannot get to a point that asks Dr. Cookett if it's thin or not, because this is not a good way of looking into it, right? But some of them are, as the one I show, are intuitively very thin. So I wouldn't do patients with this uber thin corpus callosum. The other ones maybe will fit what Mark just mentioned. It's there, so maybe functional. But when they are very thin, they are very thin, and we do have very thin kids, very thin corpus callosum in some kids. So
okay. So I guess we don't have any more points for the callosotomy, but maybe we move ahead to.
Hey, Christian, I think Jim Baumgartner had a comment on callosotomy.
Oh yeah, please.
Hi, Jim.
Yeah, so I'm sort of in Arthur's camp. So we've been doing pretty much exclusively complete corpus callosotomies for the really bad generalized. Either you're calling it generalized or multifocal. And historically, we followed that with VNS over the last year or so. We've been doing bilateral CM RNS for these patients, and we've got about a dozen. I think the initial experience has been pretty positive. I don't know how it stacks up side by side against CM DBS, but we've been doing microsurgical callosotomies and trying to do at the initial phase a complete callosotomy every time.
Okay, great.
Just I know, Christian, that you have a personal experience of starting with posterior and then having to complete. So why don't you share this?
Yeah, so after the publication from the Brazil group, we were doing a posterior callosotomy for 7 or 8 kids, and all of them ended up in completing it, just because it was not efficient that we were expecting. So What we're doing right now is we're doing a stage procedure. So I'm starting in front and then doing the last part in a separate operation, just because we felt that doing it in one stage, children were much more, dependent on it, and they were hanging in there for a couple of days. So for the stage procedure, I have the feeling that they go along with it much better, so they can be discharged earlier, and families, are experiencing not this couple of days after surgery where the children are not doing anything. So this is how we're doing it right now, doing it in 2 stages. But in the end, I think the complete colostomy is the way to go. And incomplete colostomy always leaves the question then, if it's not effective enough, then what to do with this information? Should we do then complete the colostomy, or say no, it's not working? So do we then have to move forward to VNS, RNS, or DBS? So I think there is no way to just do an incomplete procedure if we're talking about colostomy. That's my opinion on this. If you're doing it stage or not stage, or I don't think you can do a complete colostomy with a lid. I think there are always kind of these small residuals that maybe not relevant or are relevant. We don't know, but this is just an observation for me.
Christian, how long do you wait in between your stage procedures?
Couple of weeks.
Couple of weeks.
So to go home, and the advantage of this, at least in my opinion, the advantage is that I can do a very small skin incision, and a small craniotomy. It's like the craniotomy people are using for an endoscopic procedure if you want to. So then I have 2 small incisions and 2 small craniotomies, and not this large one. So I guess this is why children come along better with this. But yeah, a couple of weeks in between, and then go ahead. Okay, so I think we had a good discussion on colostomy, and there is now a question from Martin Tistel from the Great Ormond Street. It's for you, Mark. He was asking about the choice of the contact pairs that they're using for your CM electrodes. You were saying that you are using the contact pair with the largest signal. And could you explain and go into detail for that?
Yeah, sure. I think that there are 2 scenarios. Well, there are 3 scenarios. The seizure is detected at the same time and with the same amplitude on both bipolar pairs and the thalamus on one side. Or it's detected in both, but one's earlier. Or it's detected, really primarily in one of the 2 bipolar pairs. And that's what I mean by the largest signal. It's literally the amplitude of the spike wave discharge on the voltage tracing.
Mm-hmm. And I have a question for the trajectories. Does the morphology of the ventricles influence your trajectories? In terms of, if you have the feeling that you want to target the CM more medially to have a better coverage, but at the same time, to reach that, you have to pass the ventricle, would you do that? Or are you trying to avoid ventricles by every means?
I'll answer briefly and let Arthur answer. I try to avoid the ventricle, and I also try to avoid being too medial because of our initial experience where we're really targeting on the posterior lateral edge of the CM in some cases, and that seemed to be a good target region. And I have actually one patient who was a slower responder with IgE, and I asked the programming neurologist if we could replace one of his leads, reposition, because I thought it was too medial. So actually, I worry a little bit about being too medial.
Mm-hmm. And you were saying you were using the ClearPoint and the ROSA system. What is your experience in terms of accuracy for the ClearPoint? Or is there any specific patient group where you're using ClearPoint and we're using the ROSA, or is it just
Yeah, it's been in our practice, it's been based on OR availability to a large extent, just trying to get the patients through in whichever room is available. I was afraid initially that the ClearPoint method might slow us down, but we've been trying to get better and faster at that. And I think in general, just in relating DBS, doing this awake with microelectrode recording in the ROSA versus a ClearPoint. The ClearPoint is always more accurate. It's always more accurate. And frankly, it's easier, but it can take longer. So what we've been trying to do is practice and get the case time shorter. And just the direct visualization is helpful. And I'm talking about it on the order of, on average, a millimeter more accurate. But the thing that we do not have with the ClearPoint system that we'll still occasionally have with the ROSA is a 2 millimeter or more error. That will still occasionally happen. And that just does not happen with the ClearPoint system.
Mm-hmm.
I would say that contrary, for instance, to targeting the ANT, because the ANT is basically an intraventricular structure. So, and then you have to cross the ventricle, otherwise you're not going to be able to adequately target it. They tried the extraventricular way, but then you just briefly touch the nucleus. So ENT, you basically have to go transventricular, but in most of the patients, when you're targeting the central median, you would be able to do it extraventricularly. And if so, I think it'd be a better idea to do that. There is some morbidity coming from entering, it's not huge, but from the Parkinson's, the movement disorder literature, we know that when you enter a ventricle, there is a larger, possible side effect or doing that. So in most of the patients central median, it's likely going to be able to do extraventricular, and I would advise people to do that. The problem is that some kids with a generalized epilepsy, they have very enlarged ventricles, not only the lateral ones, but the third ventricle too. So it became a little bit difficult to do it without transversing the ventricle. And in some of the kids with this significant ventricle enlargement, we needed to go through the ventricle. But if feasible from an anatomical point of view, I think I would suggest you try to be extraventricular.
Mm-hmm. And there's a question on the type of leads that you're using for CMDBS. Are they directional? Or what type of leads are you using for your CMDBS? Both of you.
You're muted, Mark.
Oh, I was just saying, that one's for you, because we've stayed married to the RNS approach since we started. We just haven't had a reason to deviate. So I do not have experience with CMDBS. But
then tell us how is this RNS DBS you're using, the length, the interactive space, and things like that.
It's pretty similar to the Medtronic larger spaced. It's about 12.5 contact to contact distance. So it's 1.5 height of the cylindrical contact separated by, I think, 2 millimeters. So it's not it's an open question about what the best configuration would be. And it's probably that is not the best configuration, but it's the one that we have available. There is a longer space lead that has a total distance of about 33 millimeters, which we have some cases where this gets into these multifocal type cases that you showed, Arthur, which I think it's great that you showed those. And we have a number of these now, but we don't have the outcome. So I wasn't sure how appropriate it was to show those, but we have a number of these multifocal rapidly generalized cases where we've done SEEG, and we're considering and have tried in a few cases hitting multiple thalamic targets with the same electrode, or taking these longer spaced RNS contacts and trying to, for instance, go through the tail of the hippocampus with one bipolar pair and being in the pulvinar with the other. If we've mapped that the pulvinar is the most involved in the generalization of the seizure. So I think there's a lot of work the short answer would be, there's a lot of work to do to understand the best configuration, and we certainly have some constraints on the RNS. You can't do anything directional on those, but the general philosophy that we've taken is that it's given it's an okay trade-off with the constraints of these electrodes without having the configuration to change the stimulation shape, because we can see the signal in real time and we can at least titrate between the bipolar pairs. And that the RNS system, you can simulate a monopolar or bipolar. You can change, obviously, the recording configuration. You can have multiple detectors and stimulation paradigms. So the parameter space is quite large. So we think that those advantages outweigh let's say, the disadvantages of the electrode configuration.
Mm-hmm. When we started, we used Medtronic's 3387 electrodes. These are not directionals. But then when directionals became available, first from Boston, and then now you have Medtronic's directionals too, we moved to directionals, although the benefit of it is not yet clear for us. One of the benefits would be to be able to get rid of paresthesias if you just use the directionals. Which, to be honest, is something that people like Mark will need to teach us, because since we use continuous stimulation, you can get paresthesias in the first minutes, but then they disappear. So it's not a major issue for people using continuous stimulation. When you do RNS, it's intermittent, and if they have paresthesias, whatever time they receive stimulation, they can, and if they get paresthesias, they'll get paresthesia in most of stimulation, at least in some, and that might be a problem, and that might be helped by using the directionals. But right now we use directionals and not the old ones.
Great. Any more questions from the panelists? Bertil, I know you have a very tough voice today, but any questions?
No, really, we don't do DBS for epilepsy at all. So I have nothing to add to this discussion, but it has been two really great lectures, I think.
I mean, Arthur, you were saying that the term palliative is the term that is, an old-fashioned way to name the procedures that we're doing nowadays, and I fully agree, because it all depends on how we are measuring the outcome, right? So, and this is one of the comments from the audience as well here, that palliative is a term we shouldn't use anymore. Would you agree, Guy, Bertil?
I heard that comment, and palliative is not really a good term for it. So if you could find something else, that would be great.
It's all about how. Yes, please.
No, I was just going to say, I know that I've heard Mark talk about this before too, about in these patients who have, network epilepsy versus focal epilepsy, how we're really working to, I think one of the questions was about using the term alleviating as much of the burden, the epilepsy burden, the psychosocial burden, all the other comorbidity burdens. And so I think for all of us, yeah, it's a very good point.
Yeah, I'll say it's to give credit to Sadi Gatan, who's at Mount Sinai, who's the first person that I heard say, we got to stop using this word palliative. And I think one of the reasons why is, when you hear that, then the neurologist, even, the neurologist and everyone at the epilepsy conference just, goes like this, because they think, oh, well, what's the point? They're not going to be seizure free. And there's a lot of value to these patients in operating on them, with even if they're not going to be seizure free. And we know it's just the state, it's just reality that we can't make everyone seizure free. But the technical reason not to use the word palliative is because it means relieving symptoms and not having a direct disease effect on the disease. So I think all of these surgeries are disease modifying. There's evidence now that from RNS, but you can assume the same thing for DBS, that this does change the network. So if you turn off someone's DBS or RNS, they're probably not going to immediately go back to the same, at least some of these patients, not going to go back to the same seizure frequency and severity. They may over time, but we are probably modifying the network activity with electrical stimulation. I think the future of epilepsy surgery, part of it is that I hope we get better and better at doing this, so that you can give patients these long periods of seizure freedom. And if you do that, I think by definition, you've modified the disease, and that's not palliative. That's not just treating the symptoms. You're actually treating the disease. It just may not be permanent. You got to have the device in, but it doesn't mean that you're not modifying the disease directly.
Yeah, great.
I like disease modifying procedures. I like the term. I'm not sure if everybody like it, but if so, we could try to push it, because it's it's also cultural. In Brazil, if you tell someone that he's gonna receive palliative treatment, he or she are gonna probably be thinking, either I'm dying or my disease is too bad. It's
Right.
it's I don't know if it happens in Europe or in US, but
it's the same in Europe. I mean, the term palliative is used in cancer patients, right? So everybody is, thinking of this kind of thing.
I think that suggestion of some kind of disease modifying is really a good suggestion, I think.
Yeah.
What do you think about disease modifying procedures, Guy?
Yeah, I completely agree. I think, like you say, Arthur, maybe it's a good idea to try to formally socialize the idea of get rid of palliative in the epilepsy space.
Yeah. And I think this was a perfect conclusive statement. And we are now 5:30, at least in Europe. So I think we had a very nice discussion here. And thank you all for this. And thank Arthur and Mark for a very nice presentation. And hope to see you all very soon.
Thank you.
Okay. I'm opening the post-webinar link. Thank you.
Bye-bye.
Thanks, Mark.
Thank you.
Thanks, Mark.
Thanks, Arthur.
Thanks, Mark.
Appreciate it.